Okay, question. When or if at all do you add vaginal brachytherapy boost to external beam? What dose? Does the use of chemo influence your recommendation? So, good question. So personally, I add a vaginal brachytherapy boost to external beam for cervical stromal invasion. Other institutions will do like extensive LVSI or high risk histologies like a carcinosarcoma or clear cell, so it's a little bit institutional. I think cervical stromal invasion is the most common reason. Our dosing, again, sometimes this is different. We do 45 gray external beam and then 4 gray times 3 to 5 millimeters. That is also similar to 6 gray times 3 to the vaginal surface, which you see in some protocols. So again, doesn't matter as long as you're making sure you're pointing out where you're prescribing to. It's most important. So 45 gray, 4 gray times 3 to 5 millimeters, or 6 gray times 2 or 3 to the surface that's what they used on GUG 258. I don't usually change that based on chemo. However, again, I tend to be someone who doesn't just always add on a vaginal brachytherapy boost. So, like for an aggressive histology, because they have had chemo. So maybe it does influence me because I don't tend to do it in that population versus some other places or people that do. The other situation where you'd be adding on a brachytherapy boost after external beam is if someone had a vaginal cuff recurrence, which we didn't really talk about, but that, if you have an isolated small vaginal recurrence, you are going to add in, you're going to do pelvic radiation, and then if it's small and superficial and you can cover it with intracavitary, you can do brachytherapy boost. In that situation, I do 45 gray and 7 gray times 3 to 5 millimeter. So there's kind of 3 different scenarios with your vaginal cylinder dosing, just used alone after surgery, used after external beam for like cervical stromal invasion, and then used after external beam for vaginal recurrent disease. And they're a little bit different. So again, I do 7 gray times 3 to 5 millimeters in the adjuvant setting alone, 45 gray, followed by 4 gray times 3 to 5 millimeters for cervical stromal invasion, 45 gray, followed by 7 gray times 3 for a vaginal recurrence. If the vaginal recurrence is over 5 millimeters in thickness, then you'll need an interstitial implant. Okay, so hopefully that helps. Okay, now is it right? I'm a little confused because now it seems like my screens are backwards.
We are seeing the correct version now.
Okay, that's bizarre. Okay. Okay. All right, we will go on to cervical cancer. Matt, let me know if you have any other questions about that. Okay. So, cervical cancer, the trends, the incidence rates over the past many years has decreased dramatically. This was due to the development of PAP testing. And I need to, so dramatic increase in, or a dramatic decrease in incidence rates due to screening. And in the US, cervical cancer is not even within the 10 most common cancers diagnosed in women. So this is really a cancer of low income and developing countries. Again, incidence has decreased over the past 45 years due to screening. So this is the worldwide incidence of cervical cancer, where you can see the highest incidence in Africa and some countries in South America. So globally, the average age of diagnosis is 53. In US, the median age is 47. And Sorry, my screens are confusingly backwards here. Okay. Move the chat. Okay, so 90%, over 90% of cervical cancers are related to HPV infection, with HPV 16 and 18 being the most common. The as the virus invades the squamous epithelium, the what kind of they like you to know is that eventually the HPV DNA will integrate into the host DNA. So that's what we see over here, integration. So the stage before that is where we kind of see this pre-invasive disease, where there is an infection, but it hasn't fully integrated. And that's where we see our cervical and our, intraepithelial neoplasias and our pre-invasive disease. Once the DNA fully integrates, then we are, dealing with the invasive cancer. And next slide. There's DNA of the virus is an episome, so this kind of circular DNA, which again integrates. And then there are different components of the HPV which interact with the host and lead to carcinogenesis. So the two portions of the HPV that lead to cancer are the HPV E6 and the E7 oncoproteins. And essentially, the E6 will degrade TP53, which leads to proliferation and carcinogenesis, and your HPV E7 degrades RB, which again, through the downstream processes will ultimately lead to proliferation and carcinogenesis. So they like you to know which one the E6 and the E7 bind to. So cervical cancer screening has changed some over the past decade or so. So women, and depends a little bit on whose screening guidelines you look at. This is the U.S. Preventive Service Task Force. And for women age 21, so women under age 21 shouldn't be receiving screening, but from 21 to who are asymptomatic, from 21 to 29, it's screening every 3 years with cytology. Women age 30 to 65 can be screened with cytology every 3 years or every 5 years with HPV testing, or every 5 years with co-testing. And again, not screening for women younger than 21, or currently recommends no screening for women over 65 who had prior adequate screening, which I think is an important caveat, and women who've had a hysterectomy for benign reasons. So HPV testing is more sensitive than cytology, but can be less specific for younger women. But the specificity differences are not seen as much for older women. So that's why some of the guidelines are different for those who are a little bit older. So when we look at the prevalence of a recent screening, so how many women are actually having screening, actually it's gone down a little bit from 2005 over 2015. So I don't have like an update to this, but similar to slightly decreased, unfortunately. So HPV vaccination, there are different vaccines available. Cervarix protects against HPV 16 and 18, which are the two most common HPV types related to cervical cancer. The Gardasil adds on HPV 6 and 11, and then for the 4-valent, and then the 9-valent adds in additional strains of HPV. So this are just the recommendations for who should get the vaccine. Actually, this has been updated, so now the adults under 45 years of age can get vaccinated. But children can start as young as 9 years of age, routinely being recommended by about 11 or 12. Again, adults now less than 45, 45 or under, can get vaccinated if they have not had it already. So vaccination rates in adolescents, only about 68% have received the first dose. And then when you get to the second dose, because they do need 2 doses if they're under 15 and 3 doses if they're over 15, which is probably one of the limiting factors to this getting to people getting fully vaccinated. Only about 50% are receiving the recommended number of doses. So looking at this Swedish registry-based cohort study of the incidence of cervical cancer. So looking at this orange line, incidence in this group who are the unvaccinated is much, much higher than your vaccinated population. And when you look at the lowest group here in the green, this is those who've been vaccinated less than 17 years of age. So, vaccinating 17 to 30 is helpful, but still a possibility that there's been some exposure to HPV in that time. So again, the age-adjusted incidence if you vaccinate before 17 versus between 17 and 30. So vaccinating young is recommended. Risk factors for cervical cancer are related to the likelihood of being exposed to HPV. So early age at first intercourse, multiple sexual partners, history of STDs, low income, low education status, and smoking. Presentation is may be asymptomatic and found on a pelvic exam or after an abnormal pap test. They could present with postcoital bleeding, menorrhagia or metorrhagia, malodorous vaginal discharge, pelvic sidewall invasion can lead to the classic triad of lower limb edema, flank pain, and sciatica. There can also be symptoms from a local invasion of tumor, from invasion of the bladder or invasion of the rectum, resulting in fistulas, which causes urine or feces to be passed through the vagina. So patterns or spread are either locally through the vagina and the perimetria, but also to pelvic nodes as the first echelon. So the major routes are through the lateral pelvic and the hypogastric routes. The obturator lymph nodes are the sentinel nodes for the lateral route here, this kind of green arrow. And the junctional lymph nodes are the central lymph nodes for the hypogastric route. So this yellow line here. Less commonly, they can spread to the presacral route, where they can disseminate via the perirectal, anterior lymphatic plexus to the sacrum and the coccyx. So they can be sacral lymph node involvement as well. So for your workup, in general, you're going to do a history and a physical exam, including a bimanual pelvic and rectal exam. From this, you will be able to determine the size of the tumor and the extent of any perimetrial invasion or sidewall invasion. Pap test is not truly diagnostic, meaning you need a true biopsy to make the diagnosis of cancer, but it is often the first test, followed by a colposcopy if the pap test is normal, conization for subclinical tumors, biopsies, DNC if needed, and a cysto and a rectosigmoidoscopy for more advanced stages, particularly if you're concerned about bladder or rectal invasion. We don't routinely do them unless there's a reason to. Standard imaging, prior to the change in the staging in 2018, the imaging that was used was chest X-ray, IV pylography, and a barium enema. You could use a CT scan to assess for hydro. However, the staging has recently changed, so now I would say the standard imaging workup is a PET scan plus or minus MRI. MRI is not, it's helpful, but is most important to assess for the response prior to brachytherapy. And of course, you said blood work, including a CBC, a pregnancy test if the woman is young, and blood chemistries. What is the clinical stage of a cervical cancer that is 2.5 centimeters visible with superficial invasion? So the cervical cancer staging was updated in 2018. Stage 1 are cancers that are confined to the cervix, with your 1As being cancers that are not clinically visible. So these are getting picked up on colposcopies or small or procedures, but not visible to the eye. So these are diagnosed only by microscopy with a maximum depth of invasion of less than 5 millimeters, with the cutoffs from 1A1 to 1A2 listed there. 1B1s are either more invasion, so greater than 5 millimeters invasion, or a visible lesion. So 1B1 is less than 2 centimeters. 1B2 is 2 centimeters to less than 4 centimeters. And a 1B3 is in a cancer grade 4 centimeters or greater in greatest dimension. Stage 2 is 2A is upper vaginal involvement without perimetrial invasion. A 2A1 is a cancer less than 4 centimeters involving the upper vagina, and a 2A2 is a invasive cancer greater than 4 centimeters, 4 or greater, involving the upper vagina. 2B is perimetrial extension, but not to the sidewall. Stage 3A is distal vaginal involvement. 3B is pelvic sidewall extension and or hydronephrosis. And 3C1 is pelvic lymph node metastasis. 3C2 is parotid lymph node metastasis. 4A is invasion of a surrounding organ, including bladder or rectum, and 4B is distant. So again, here's your stage 1. This is your microscopic disease, 1A1 less than 3 millimeters, 1A2 is 3 to 5 millimeters, and then your clinically visible lesions. 2 is extending into the upper vagina with different designations based on size, or perimetrial extension, so spread laterally essentially. 3A is down to the vagina. 3B is out to the sidewall or to the lymph nodes. And then 4 is again local extension to the bladder or the rectum or spread to another organ. Pop quiz, what is the best treatment for a 28-year-old woman with a 2 centimeter visible squamous cell carcinoma of the cervix, extending to the posterior vaginal fornix with no other evidence of disease? A, brachytherapy alone. B, external beam and brachytherapy. C, modified radical hysterectomy and pelvic lymph node dissection. Or D, a LEAP with negative margins. So here's the treatment recommendations. And there has been some recent publications just this month with the SHAPE trial, which it does affect some of these earlier stage. Prior to that, and I'm not totally sure if that's going to completely change practice, so I can discuss that in a second. But for a 1A1 with no LVSI and extrafascial hysterectomy is standard. And then for just about everyone else from a 1A, you know, any others, a more radical surgery is recommended. Modified radical for a 1A1 or 1A2, with the radical hysterectomy being recommended for 1B1s, 1B2s, and 2A1s. So the pop quiz, this patient would have fallen into this radical hysterectomy group. So the SHAPE trial, which was just done, is looked at some of the earlier stage. I don't have it off the top of my head right now, but it was kind of these earlier stage where the modified radicals were recommended. They were randomized to a simple hysterectomy versus a radical hysterectomy, and there did not appear to be a difference between the two. So some of these recommendations will probably be changing for the early stage cancers. But again, that's pretty new data. So we kind of looked at this with the endometrial lecture, but the surgical treatment is different than a endometrial cancer. So the extrafascial hysterectomy removes just the uterus. The modified radical is going to remove some more of the perimetria versus the radical, which is going to go out to the sidewall. And each removing a little bit more of the vagina. So the modified radical removes about 1 to 2 centimeters, and then the type 3 radical hysterectomy will remove the upper third. And some of the other differences are listed there for you. So this is kind of the same. For the type 2 modified, the ureters are dissected to the point where they enter the bladder. The uterine arteries are sectioned and ligated at the medial half of the perimetria, and the resection of the proximal uterosacral ligaments and medial half of the cardinal ligaments with 1 to 2 centimeters of the vagina. The type 3 hysterectomy removes removes as much tissue as possible from the uterosacral ligaments. Perimetria resected to the pelvic wall. Uterine vessels ligated at the origin, and the upper third of the vagina is removed. So the Landoni study was a study looking at surgery versus radiation for early stage disease. This was an Italian study, looked at radical hysterectomy plus pelvic lymphadenectomy versus radiation given through a 4-field box plus LDR brachytherapy to a median dose of 76 gray, which we of course know now is relatively low. We know that the study showed, sorry, my chat keeps getting in the way. So the radiation group had, minimize that for a second, a better overall survival, and it was not significant in all arms, but there was some more improvement in the bigger tumors. Sorry, I'm having trouble with this chat. Oops. Okay. All right. And let me go back to the other arm because it does, oh, no. Okay. So in these, when you're looking at larger cancers, we see a more significant difference in the overall survival with radiation compared to surgery. And what isn't really stated here is that a lot of the patients randomized to the surgery group ended up getting postoperative radiation. So really probably even changing the outcomes more in favor of radiation. And the radiation was pretty low dose, so done in modern times could have different outcomes. But really, no major difference between the two, so they were considered to be equivalent options. But again, noting that the larger tumors, the survival was worse in that group, and there was more side effects in the people who had both treatment modalities. So those who had surgery and adjuvant radiation had more toxicity. So who needs postoperative radiation after radical hysterectomy? So the SEDLIS study um, looked at women with these risk factors. So it's a little bit of a confusing table. The risk factors include LVSI, stromal invasion, and tumor size. And these were women after radical hysterectomy who had negative nodes, margins were negative, and their parametria were negative. And there were, again, different criteria needed depending on the presence of, the stromal invasion. So you could have LVI, deep third invasion, and any tumor size. But again, it was a little bit different. So in general, we say that if they had deep stromal invasion, a tumor over 4 centimeters, and LVSI, those are criteria. But again, it's a little more nuancey than that. But those are the basic criteria. So in this study, they randomized patients to postoperative pelvic radiation, 46 gray to 50.4 gray versus observation in women with stage 1B cervical cancer. The primary outcome was recurrence-free survival. And the eligible patients were those with a 1B cancer, negative lymph nodes, and 2 or more of the following: more than 1/3 deep stromal invasion, capillary lymphatic space involvement, and a tumor diameter of 4 centimeters. Again, with the caveat of referring back to that chart for some of the finer details. And the outcomes showed that there was improvement in progression-free survival in the radiation arm. The overall survival did not reach statistical significance, but did appear improved in the radiation arm. So post-operative chemoradiation, the Peters criteria, positive margins, positive lymph nodes, or positive parametria. So these are your high risk factors after hysterectomy. So this trial compared adjuvant chemoradiation with adjuvant radiation in patients with early stage high risk patients. The eligible patients had clinical stage 1A2, 1B, or 2A, and were treated with radical hysterectomy and pelvic lymphadenectomy, and had at least one of the following: positive pelvic nodes, positive margins, and positive parametria. Radiation was 49 gray on 29 fractions given through a 4-field box. Brachytherapy was not permitted. Chemo was cisplatin and 5-FU every 3 weeks, or fluorouracil given every 3 weeks for 4 cycles. Cycle 1 began on day 1 of radiation. So not just weekly cisplatin. And this showed improvement in progression-free survival and overall survival for those who received concurrent chemotherapy with the radiation. The 4-year progression-free survival was radiation alone, 63%, chemoradiation, 80%. And 4-year overall survival, radiation, 71%, chemoradiation, 81%. So a 10-year improvement in overall survival with the addition of concurrent chemotherapy. So this was the STARS-3 trial. This was the effectiveness of sequential chemoradiation versus concurrent chemoradiation or radiation alone in the adjuvant treatment after hysterectomy. I don't think this has been, practice changing, but this is a phase 3 randomized study comparing these 3 arms, and eligible patients had at least one adverse factor. Kind of a combination of the high risk and the intermediate risk, which probably, limits the study to some extent. And the radiation was 45 to 50 gray. Weekly cisplatin was used for concurrent chemoradiation, and cis-Taxol was given 2 cycles before and 2 cycles after for the sequential. And this study showed an improvement in those who received sequential therapy with a higher disease-free survival and a 5-year overall survival. So what trials led to definitive chemoradiation plus brachytherapy as a standard of care for more advanced disease? So the standard for your locally advanced are pelvic radiation with concurrent cisplatin plus brachytherapy. And with appropriate treatment of the lymph nodes based on imaging or surgical assessment. So for pelvic node, the periodic lymph node negative can treat the pelvis plus or minus the periordics. If they have known periodic involvement, then you definitely need to do an extended field external beam treatment plan. So there was about 5 studies. These are 3 that are listed, but there were more studies that led to the to chemoradiation being standard of care for locally advanced cervical cancer. RTG 7920 didn't use concurrent chemotherapy, but this was a study that looked at standard pelvic radiation versus pelvic plus periodic lymph node radiation and high-risk cervical cancer. And eligible patients had a cervical tumor over 4 centimeters with invasion into perimetria. And the radiation dose was 45 to 50 gray, followed by brachytherapy or pelvic plus periodic lymph node radiation and brachytherapy. And this study showed an improvement to adding the extended field to the external beam. Again, no concurrent chemotherapy here, but improvement with the periodic field. And then that led to RTG 9001, which is a randomized trial comparing extended field radiation to pelvic radiation with concurrent chemotherapy. And these were locally advanced cervical cancer patients with pelvic lymph node metastasis, but no periodic lymph nodes. So they were excluded if they had known periodic disease, with the improvement being overall survival. Again, this was old 44 field techniques, but did give at least 85 gray to point A. The extended field went up to L1, L2, where the standard pelvic field was L4, L5. And the treatment was recommended to be completed in less than 56 days. The chemo was cisplatin plus fluorouracil, day 1 of radiation, and administered every 3 weeks for 3 cycles. And this study showed that the, when you're looking at the radiation plus chemo group, that the 5-year and 8-year overall survival was better than those who received pelvic and periodic lymph node radiation without chemotherapy. So better disease-free survival, less local, regional, and nodal failures. And toxicities were be a little bit higher in the, although grade 4 was similar in both, a little more grade 3s in the chemo group, and 2 grade 5s in the other, in radiation alone. GOG 120 was the study that established weekly cisplatin as a standard systemic therapy for locally advanced cervical cancer. So this was, again, locally advanced patients, 2B, 3, or 4A, who had no periodic lymph node metastases. The radiation dose was external beam plus brachytherapy given through a 4-field technique, and with point A dosing. And there was 3 different chemotherapy arms. So cisplatin alone, cisplatin, fluorouracil, and hydroxyurea alone. And basically both of the arms with the cisplatin did better than the hydroxyurea arm. And there didn't seem to be a benefit to adding on the additional agents. And so that's really what kind of established cisplatin alone weekly as the standard chemo given with the radiation. When is brachytherapy needed for cervical cancer? Or is it when or why? Sorry, why is brachytherapy? Okay, so we have pretty large tumors for these patients. The patients that we see who are referred for definitive radiation, chemoradiation, usually have pretty advanced disease. And for external beam, we take into account the GTV, the CTV, and the PTV. The target is also mobile, so we know that the uterus can change positions a lot depending on bladder filling. So here's an MRI with a full bladder. Here's the uterus and a full bladder, and then with the empty bladder, the uterus falls out of actually the radiation field, or at least that the purple. If that's the full dose, the uterus is kind of falling outside of that. So it's a big volume. I mean, it's a big target. It's a mobile target. And brachytherapy is very important for limiting dose to the surrounding normal tissue and getting enough radiation to the target without overdosing ear, bowel, rectum, and bladder, as these would really limit what we could do if we were trying to give external beam alone. So HDR compared to LDR, the HDR, the treatments can be given just in over a few minutes time. The source is iridium 192 with a half-life of about 74 days. It is better for staff as there's no exposure to the source. LDR was delivered quite slowly, 0.7 to 0.7 gray per hour, so patients were admitted for 2 to 3 days with their implants. Source was cesium, and also iridium, but cesium was the main source. The half-life was 30 years, but it did result in a lot of exposure to staff. This is some pictures of how it used to be done. We still did LDR when I was a resident, so we had this is a big metal shield or a shield that was placed at the patient's bedside so that the nursing staff could come in and try to take care of them while being protected from the radiation. So now we've moved on to HDR. So this is the afterloader, which is used to house the source and keep the staff safe. So different applicators are going to be pretty institutional. So we use both TNO, or you can also use tandem, ring and tandem. Here, there isn't necessarily one that's, better than the other, but some type of intracavitary applicator is used for the locally advanced cervix, depending on the size of the tumor at the time of brachytherapy. So you do want to consider the extent of disease and the size when determining what type of applicator you need. So if you have more extensive disease than can be covered with your brachytherapy, then you'll need to consider interstitial implant. So they come in different angles and different tandem lengths. And again, kind of the old school way of doing this was a tandem was placed along with a vaginal applicator, and points were placed on orthogonal imaging, point A being 2 centimeters above the os and 2 centimeters lateral to the tandem, with point B being 3 centimeters lateral to that. And point A was the location of the paracervical triangle where the uterine vessels crossed the ureter. And point B was supposed to represent the dose to the obturator nodes, and this dose was about 1/3 the dose of point A. So now so these are the old ICRU bladder and rectal points. So the bladder point was placed on the posterior portion of the Foley bulb on the imaging, and the rectal point was placed 5 mm posterior to it was really posterior to the ring, so probably should be up maybe a little bit higher, but posterior to the vagina. And that would be visible because there would be packing in the vagina, and so they'd put the point 5 mm posterior to that. There was no sigmoid point and no dose to the bowel considered. So again, here's how they kind of used to do it with a bunch of points and just on these x-rays. So still seems kind of crazy to me, but now we have moved on to volumes and CT-based brachytherapy. Our institution still puts the points in. We don't necessarily prescribe to them anymore, but we do put them in for a reference. But now we are contouring our volumes, our high-risk CTV, along with our bladder, rectum, sigmoid, and bowel. And the newest form of brachytherapy is MR-guided brachytherapy for better CTV delineation. And we know that when you're looking at 2D and MRI-based brachytherapy, that there are definitely advantages to doing MR-based brachytherapy in terms of local control and reduced toxicity. So with MR-based brachytherapy, we're able to customize the dose and make the dose much more targeted so we can spare the sigmoid and other OARs much better. Interstitial brachytherapy, again, different templates depending on the institution. This is the Syed Neblet template, which can be used for those with significant parametrial involvement after chemoradiation, or for vaginas which are too narrow to accommodate a ring or ovoids, and or for distal vaginal involvement that needs kind of more coverage than what an ovoid or a ring can provide. And the benefit of the needles with the interstitial brachytherapy is to extend the kind of laterally, essentially what you can cover. So you can see in A, it's a pretty small tumor there, that red circle, and after external beam, the cancer is quite small and can be covered well with this intracavitary plan, versus in B, where you have this bigger tumor. If you have an intracavitary, so it's kind of this yellow being your kind of pear-shaped dose distribution that you get from your intracavitary plan. This can't cover the lateral extent very well, but if you add in some interstitial needles on that side, you can cover the tumor well. So we know that the rate of toxicity is much higher with two-dimensional external beam and brachytherapy versus IMRT and 3D guided brachytherapy. So this is reduced late grade 3 toxicity with more modern treatment. And looking at prospective data, GU toxicity with MR-based brachytherapy, overall quite low. We see fistulas for all comers are about 0.6%, grade 3, 0.4%. And we know that even lower for those who had no bladder invasion at the time of diagnosis. So very low overall. And rectal toxicity from prospective data, So majority of rectal toxicity is going to be lower grade, but we do see some grade 3 and grade 4. However, this is bleeding in A and then proctitis in B. So majority are early, like grade 1 and 2. Vaginal toxicity. I'm getting more and more data on this with Embrace studies as they're being published. But overall, we do see pretty, um, much more grade early, lower grade toxicities in terms of stenosis, etc. The rate of significant toxicity, again, is pretty low with modern techniques, about 19% overall for grade 2 and 2% for grade 3. And in addition to decreasing toxicity, we know that MRI-guided brachytherapy improves survival over two-dimensional or CT-guided even. 84% versus 56% at 2 years. So the timeline for your definitive treatment is after you have your biopsy, your labs, you get your imaging, and assess the lymph nodes. If there are involved or suspicious lymph nodes, you can consider a parodic lymph node dissection robotically. That's not necessary, but sometimes it's done. We sometimes do it if the lymph nodes are really, really bulky. But if they're small, we typically will just proceed with the radiation. So it's 5 weeks of external beam brachytherapy, 45 gray, weekly cisplatin, 40 milligrams per meter square, with brachytherapy starting around week 4 or 5. And it's extremely important to be timely and to complete your chemoradiation within ideally 56 days. And we know that the survival will be decreased as you extend the duration of your treatment. So treatment compliance and timing of treatment is very important. Okay, so the Outback study was looking at doing standard chemoradiation for these locally advanced tumors and then adding additional chemotherapy. So this was concurrent chemoradiation versus concurrent chemoradiation followed by adjuvant chemotherapy. And the radiation concurrent was standard cisplatin, and adjuvant chemo was kind of the standard carbotaxol dosing. The radiation was whole pelvic, with the option to extend the field if there was common iliac lymph node involvement. You could get an external beam boost if for some reason brachytherapy could not be performed. Interstitial brachytherapy initially wasn't permitted, as for if you knew they needed an interstitial, they weren't a candidate for the study, but it did end up being allowed to be done if clinically necessary, and parametrial nodal boost could be done. And there was no difference in overall survival at 5 years with those who received a chemotherapy, the adjuvant chemotherapy versus standard chemoradiation alone. So this was determined to not be something that should be done. So adjuvant chemotherapy was taken off kind of the books as a treatment option after chemoradiation, as there was no improvement in overall survival or progression-free survival. Some more recent data looking at the use of immune therapy. Oops, sorry. So Pembro was initially approved for the persistent recurrent or metastatic disease based on the Keynote 826, which showed an improvement. And then moving into the upfront setting, CALA was a study done with standard chemoradiation plus or minus durvalumab. And unfortunately, the progression-free survival was not different in the durvalumab group compared to the standard chemoradiation arm. And 24-month progression-free survival was 65.9% in the durvalumab group versus 62% in the placebo group. And some new studies in abstract form. Interlace was a study done in, this is kind of older staging, so not the most recent staging. So again, kind of affects some of the useful, like where this new data is being used. But Interlace was done in 2008, 1B1 node positive, 1B2s, stage 2s, 3Bs, and 4As with negative periodic lymph nodes. They were randomized to induction chemotherapy. So we just learned from the Outback study that additional chemotherapy after chemoradiation did not improve outcomes. So this is looking at giving it upfront. So induction chemo, carbotaxol, weekly, so a little bit lower of a dose due to the weekly schedule times 6 weeks, followed by chemoradiation versus no induction chemotherapy. And this study found an improved 5-year progression-free survival of 73% with induction chemo versus 64% with the chemoradiation, and improved 5-year overall survival as well. This came out around the same time as Keynote A18, which was a more modern study accrued more recently. Interlace accrued about over a 10-year time span. Different populations, so this was 1B2 to 2B node positive, or the 2014 staging. So this is back to your clinical staging, the clinical stage 3 with pelvic sidewall extension, not positive nodes, but that's important for the FDA approval. And to 4A, they're randomized to standard chemoradiation with brachy plus or minus pembro concurrently and for 15 cycles. And the pembro arm did show a statistically significant improvement in progression-free survival versus the placebo. And the 24-month progression-free survival was 67.8 with pembro versus 57.3 in the placebo. And the median progression-free survival was not reached. And in January 2024, the FDA approved pembro for 2014 stage 3 to 4A. So this is not the 2018 staging. This is clinical stage 3. This is pelvic sidewall extension, cervical cancer. I think that is it. Okay. Any questions on that, on cervical cancer? Okay, well, we can take a break to the top of the hour before we come back for vulva.